Dr. Anitha, MBBS, DGO, DNB, FMAS, consultant obstetrician and gynecologist, PSO, Ramesh Hospital. Completed MBBS and post-graduation from Kaktiya Medical College, Warangal. DLP from Muslim Yatmana Maternity Hospital, Hyderabad. Trained in laparoscopy from World Laparoscopy Center, Kuragaon. For the past 12 years, I have been associated with hospitals in Hyderabad and into providing comprehensive prenatal care with special area of interest in high-risk obstetrics, gynae endoscopy, working with goal towards ensuring increasing safe vaginal deliveries, reduction of cesareans deliveries, promoting cause of PCOS. I welcome you, madam, for today's CME, and please start.
Thank you, sir, for the kind introduction. Very good afternoon to one and all. At the outset, I'd like to thank Omega Hospitals, GOGS, for this opportunity today. Respected seniors, colleagues, friends, and to all my juniors. After the extensive and thought-provoking lectures by the eminent speakers, I hope I catch little attention of yours, especially the pre-lunch session. So, cervical cancer elimination, where do we stand and the way forward? Why this topic today? In spite of cancer cervix being the only cancer vaccine preventable cancer, having so many screening guidelines, why do we still talk about the cancer elimination today? Because as per the Globocon, the cancer cervical disease burden. Globocon is a global organization which has a registry for all the cancer data of all the cancer, the load, the incidence, the burden, the cancer providing deaths. So as per the Globocon 2020, the incidence of cervical cancer in India in 2020 is around 96,922 new cases, and the world over it is around 6,04,127 cases. The mortality, again 60,000 cases, and in the total world it is around 3,41,000. India leads to 23% of the global burden of cervical cancer, as well as the rest of the world. India, the cause of cervical deaths in cervical cancer is around 25%. So the disease burden annually, as we've already said, is around 60,000. So approximately 185 to 200 women die every day. Approximately 8 women die every hour. And every 8 to 9 minutes, a woman dies because of the burden of cervical cancer. The key facts of the cervical cancer: it is the 4th most common cancer among the women globally, and the 2nd most common cause of cancer deaths. The main cause of this cervical cancer is the human papillomavirus, with the cancer-causing virus 16 and 18, which is responsible for nearly 50% of the high-grade cervical precancers. HPV is mainly transmitted through sexual contact, and most people are infected with HPV shortly after the onset of sexual activity. That is the reason for vaccinating the young girls. More than 90% of them clear the infection eventually. Women living with HIV are 6 times more likely to develop cervical cancer. So vaccination against HPV and screening treatment of pre-cancer lesion is a very cost-effective way to prevent cervical cancer. Cervical cancer can be cured if diagnosed at an early stage and treated promptly. So the world over, many various organizations or bodies have come up with a comprehensive cervical cancer control strategies, wherein the most important is the primary prevention, the vaccination against HPV, the secondary prevention is screening and treatment of precancerous lesions, the tertiary prevention, diagnosis and treatment of invasive cervical cancer, and availability of palliative care for all the advanced stage of cervical cancer. So the majority of the disease burden is in the low and the middle income group countries. So 9 out of 10 women die from cervical cancer live in the low and the middle income group. The likelihood that a woman living with HIV has 6 times more higher risk than those without it. So the global strategy towards eliminating cervical cancer as a public health problem, in 2020, the World Health Assembly, with around 174 countries together, has come up with a strategy for elimination of cervical cancer. So the World Health Organization has come with a motto, a slogan of 90-70-90, a target towards elimination of cervical cancer. So the World Health Assembly has defined the elimination of cervical cancer as up to a country reaching the threshold of less than 4 cases of cervical cancer per 1 lakh women per year. To reach this threshold by the end of 21st century, the WHO has set up this 90-70-90 target, wherein 90% of the girls are fully vaccinated against HPV vaccine by the age of 15. 70% of the women are screened with a high performance test by the age of 35 and again by 45 years of age. And 90% of women identified with cervical disease receive treatment. That is 90% of the women with pre-cancer are treated, 90% of women with invasive cancer are managed. So the WHO has developed certain guidelines and tools for this. So the main important theme is the primary prevention, wherein vaccination of the girls between 9 to 14 years is the HPV vaccination, and along with that, girls and boys should be offered as appropriate the health information and warnings about the tobacco use, sex education tailored to the age and culture, condom promotion and provision for those engaged in sexual activity, and a thought about the male circumcision. The secondary prevention comes from 30 years of age for women from the general population of 25 years of age for women living with HIV. Screen with a high performance test equivalent or better than HPV test, followed by immediate treatment or as quickly as possible after an HPV molecular positive testing is done. The tertiary prevention is treatment of invasive cancer at an age with surgery, radiotherapy, chemotherapy and palliative care. So coming to the 2020 to 2022 global Indian cervical cancer profile, we have seen the rates of morbidity and mortality of the crude cervical cancer incidence per 1 lakh women is around 18.7%. The age standardized cervical cancer incidence is around 18%. The cumulative risk of cervical cancer around the ages 0 to 74 is around 2%. The cervical cancer mortality to incidence ratio is around 0.62%. So the population-based cancer registry do exist in our country. So the main primary prevention is the HPV vaccination program coverage among girls in the 2020, though the HPV vaccination is not included in our national vaccination schedule. The secondary prevention is national screening program for cervical cancer does exist. The primary screening test used is the most as our country is still a low resource based setting. The VIA, visual inspection by acetic acid, target age range of program 30 to 65 years. So the screening for cervical cancer, that fewer than 1 in 10 women have been screened for cervical cancer in the last 5 years. India, still the cervical cancer screening program has only reached to 3.1%. And the most important is the treat and supportive care. So the cancer diagnosis and treatment services available in our country by 2021. Yes, we do have a cancer center or cancer department at tertiary level, wherein we have pathological services, cancer surgeries, chemotherapies and radiotherapies are available. The number of medical staff per 1 lakh cancer patients, the radiation oncologists as by 2019 are around 3, the medical physicists 16, surgeons by 2009 are 273, the radiologists 2019 346, the nuclear medicine physicians are 3. So the palliative care for patients in the public health system generally available by 2021, yes, we do have the primary healthcare facilities as well as the community or home-based facilities. So cancer cervix is the vaccine preventable disease because women are losing their life to cancer cervix. Majority of patients are from the reproductive age group as well as up to 40 years, which is the most productive age group for our global development of our country. So population immunized against cervical cancer is still very, very less. Of all these cervical cancer deaths, 27% of deaths occur in India and the screening rate is only 3.1%. So as Dr. Sharma has detailed about the HPV vaccine, the cancer causing HPV vaccine, 16, 18, 31, 33, 45, 52 and 58, and the most common of them are HPV 16 and 18, and the what causing cancers, the HPV 6 and HPV 11. So there is a need for multivalent HPV vaccine for broader HPV protection. So this is a spectrum of how the HPV enters to the stage of the cervical cancer. So vaccinate early, that is wherein we have an opportunity of identifying and start a vaccination at an early age as early as 9 years of age, and HPV infection prevention by vaccination as well as a screening opportunity between 21 to 65 years of age group, and addressing all the precancerous lesions, thus prevention to progression to the cervical cancer. So the efficacy of the quadrivalent HPV vaccine has shown protection by 98% of cervical cancers as well as the precancerous, the CIN2 and 3, and 100% protection against the vulvar and vaginal precancers, and 99% protection against the genital warts. So the world over, the WHO, the FDA and the other regulatory bodies have certified the safety profile of HPV vaccination. So where do we play a role? The OBGYN, the ACOG has said that OBGYNs play a critical role in women's care and should assess and vaccinate adolescent girls and young women with HPV vaccine during the catch-up period. Because I think all of us do relate to this, that as an obstetrician, as a female in the department, most of them, we do not treat the patient itself, we treat the families as well. So many of them come with various doubts regarding issues and complaints with their other family members. So that is the right time to catch hold of the lady and identify, educate them about the availability of vaccination, the screening test, and regarding the the symptoms and signs of cervical cancer. So why should we prioritize the HPV vaccination? Because we see, we treat, and hence know the damage the cervical cancer can cause to a woman. We have the opportunity to catch up the HPV vaccination because they come to us with various complaints, and India has a huge female population between the age of 9 to 45 years. So FOGSI recommends vaccinating girls, women at various stages in their lives with relevant vaccines. And the most important step where we can help is vaccinating women in their postpartum status, because as the vaccination stage is still in the nascent stage, I think identifying women they have just delivered who come to us in the postnatal stage, it is an ideal time to suggest regarding the vaccination. Because HPV infection does persist during the pregnancy because of the changes of the hormonal as well as the immunological response. There is a high prevalence of HPV in the postpartum women, and only few women were positive for one or both the oncogenic HPV types. So majority of this group can still benefit from vaccination. The postpartum HPV vaccination is associated with a favorable rate of vaccine completion. So HPV does not discriminate by age. So we have seen that this graph shows the various ages wherein the HPV can infect the young girls to women over 45 years of age group. So the risk of progression from CIN1 to CIN3 and cancer cervix increases with age. So vaccinating women from the 15 to 45 years age group is very helpful, because risk progression from CIN1 to 3 is 7 times higher for women more than 30 years of age than for women less than 20 years of age. So cervical cancer, the HPV vaccine is found to be efficacious even in the mid-adult women. And there has been 0 breakthrough cases. There is a 10-year follow-up study where the vaccination of the young girls before the sexual intercourse, they have identified that there has been no breakthrough case of cancer cervix in these women. Thus, screening is very important for cervical cancer prevention. Along with this vaccination have shown the efficacy, wherein this light blue shows that vaccination along with screening, which showed 61% in prevention of cervical cancer. So screening alone enough for preventing cervical cancer? Then why vaccination? Because by screening, the exact positivity rate, because women keep getting infected till the age of 45-65 years. So in between, even though the virus has been cleared from their body, they still do not develop, they do not get infected by the different variants of the HPV vaccines. There are many variants of HPV vaccine. So vaccinating is a very important modality along with the screening. So the 3 HPV vaccines that are marketed in our country, the bivalent, the quadrivalent and the newer monovalent vaccine, all these 3 vaccines are highly efficacious in preventing infection with the major cancer causing vaccine, which is the 16 and 18, together responsible for approximately 70% of the cervical cancers globally. The vaccines are also highly efficacious in preventing precancerous lesions. The quadrivalent vaccine is also highly efficacious in preventing anogenital warts and a common genital disease, which is virtually always caused by infections with HPV 6 and 11. The nonavalent provides additional protection against 31, 33, 45, 52 and 58 along with the 16, 18, 6 and 11. The quadrivalent costs around 3,500 and this nonavalent vaccine is around 10,000 in the present day. So the data collected from various clinical trials and initial post-marketing surveillance that has been conducted in several countries showed all these 3 vaccines to be safe. So the primary target group in many countries for recommending HPV vaccination in young adolescent ages is between 9 to 14. All 3 vaccines, the vaccination schedule depends upon the age. So females less than 15 years of age, the time of the first dose, a second dose schedule is 0 and 6 months is recommended. If the interval between the doses is shorter than 5 months, then a third dose should be given at least 6 months after the first dose. Females over 15 years of age at the time of the first dose, a 3-dose schedule of 0 to 6 months is recommended. A 3-dose schedule remains necessary for those known to be immunocompromised or HIV infected. With this evidence, SAGE is a regulatory body of WHO. The strategic advisory group of experts for immunization has recommended updating HPV vaccine schedules accordingly. So instead of the 3-dose schedule, we can go with the 1 or 2-dose schedule for the primary target of girls aged between 9 to 14 years, 1 or 2-dose schedule for young women aged between 15 to 20 years, and 2 doses with a 6-month interval for women older than 21 years. The SAGE has come with a recommendation on single-dose HPV vaccination, which could be a game changer in forging towards the global strategy's 90% target for vaccination by 2030. I think with this present study, wherein there is loss of compliance or because of the cost issues and financial issues, the single dose vaccination can definitely be a game changer in this strategy. So coming to the secondary prevention, which is screening and treating. So every country must step up and scale up the HPV screening for women between 30 and 49 years. Elimination of cervical cancer as a global health issue is within reach for all countries. So the FOGSI has given the GCPR guidelines, the good clinical practice recommendations, which is come up with a level of evidences wherein these FOGSI has given recommendations as per the good resource settings or the limited resource settings. So according to that, the modality in good resource setting wherein you go screening with the HPV testing, primary HPV testing and co-testing with HPV as well as the PAP test, or cytology alone, colposcopic and colposcopy guided biopsy or the BIA. The limited resource settings, we have the visual inspection of acetic acid followed by the colposcopy if wherever feasible, plus or minus the biopsy. The target age group in high resource settings is between 25 to 65 years. As per the GCPR guidelines, the limited resource settings, it is around 30 to 65. And in postmenopausal women, screening with BIA may not be as effective when compared with the PAP test. So when to start? What is the right age to start? So in the high resource testing settings, it is testing at 25 years of age and co-testing at 30 years of age. By co-testing, we mean testing along with the PAP as well as the HPV testing. In low resource settings, start the screening from 30 years of age. So the frequency, how frequently do we do? In high resource settings, the primary HPV testing or the co-testing once in every 5 years, cytology every 3 years. And every 5 years in the low resource setting, at least 1 to 3 times in a lifetime. When do we stop this screening? 65 years with consistent negative results in the last 15 years of age. Women with no prior screening should undergo tests once at 65 years, and if negative, they should exit this screening. And how do we follow up and give treatment? The HPV testing is the preferred testing in the high resource settings, or cytology once in 12 months. And in the low resource settings, it is the BIA in 12 months. The screening following the abnormal reports for CIN2+, irrespective of the mode of treatment, continue the screening for 20 years of age. Screening in an hysterectomized patient. Following hysterectomy in which cervix has been removed for benign causes, there is no need for screening unless there is a history of pre-cancer cervical intraepithelial neoplasia. Absence of cervix must be confirmed by clinical records as well as examination. It's not just that the woman has said that she's underwent a hysterectomy and we do not examine and just leave her. If indications for hysterectomy are unclear, screening may be performed at the clinician's discretion. Then how do we follow up in women with CIN in hysterectomy with an HPV report? Need to be screened with HPV at 6 months and 18 months. So in coming to the summary that is given by the WHO, the recommendation for general population, it suggests either the HPV DNA detection in screen and treat approach starting at the age of 30 years with regular screening every 5 to 10 years, or the HPV DNA detection in a screen, triage and treat. This is the new approach that is coming. Either the screen and treat in low resource setting wherein we lose women for the loss of compliance, and the next wherein the high resource setting and the woman is educated, they are compliant, wherein we go for the screen, triage and treat approach, starting at the age of 30 years with regular screening every 5 to 10 years. So WHO suggests the following strategy in cervical cancer prevention among women with HIV. Do the HPV DNA testing in a screen, triage and treat approach starting at the age of 25 years and regular screening once in every 3 to 5 years. So coming to the screen and treat approach, the first in the low resource setting, the visual inspection by acetic acid as a primary screening test followed by the treatment. The HPV DNA detection test, self or clinician corrected as the primary screening test followed by the treatment. The screen and triage and treat approaches, cytology as the primary screening test followed by the colposcopy triage followed by the treatment. The HPV DNA detection as the primary screening test followed by the HPV 16-18 triage followed by the treatment, and using VIA triage for those who screen negative for HPV 16 and 18. HPV DNA detection as the primary screening test followed by the VIA triage followed by treatment. The HPV detection as a primary screening test followed by a colposcopy triage followed by the treatment. HPV DNA detection as a primary screening test followed by cytology triage followed by colposcopy and treatment. So regular screening intervals, this applies to a woman who had either negative screening results or has completed and recommended additional follow-up after treatment and was thus eligible to return to regular screening intervals. Follow-up of a woman with a positive primary screening test but a negative triage test, and follow-up of the women after treatment. So, based upon your resource setting, do you presently screen by cytology? Yes. Is our particular lab standardized? Do the quality indicators regarding diagnostic accuracy, training, coverage and follow-up etc. are with the standard protocols? If yes, yes. Can our hospital or the patient afford the HPV testing? If no, continue the screening with cytology. If yes, switch to primary HPV testing or co-testing. If our lab doesn't meet the quality indicators, so if our hospital can afford with the HPV testing, yes, we can go ahead with cytology, do the triage, go in with the VIA. If the hospital or the patient cannot afford the HPV testing, go with the VIA alone. And continues once the hospital is not able to or the patient is not able to afford with the HPV testing, continue screening with cytology, and if any positive test, go with colposcopy and biopsy and appropriate management. If the patient can afford, switch to the primary HPV testing or co-testing. So, basing upon the reports, as the previous speakers have detailed about the ablation, excision and the management of cervical treatment, as per the FOGS GCPR guidelines, we can go ahead with the management. So, screening of women aged more than 30 years with the primary HPV testing. So, if the patient is affordable, we go with the HPV testing. The HPV test is negative, return to the normal routine 5-year screening protocol. When HPV testing is positive, basing upon the VIA negative, repeat the HPV test at 1 year. Once negative, then she goes back to the screening pool, the regular screening pool. If HPV is positive, go with the colposcopy and biopsy. If normal, repeat the HPV test at 1 year. If abnormal, again follow the FOGS CIN management GCPR guidelines. Then HPV positive, the cytology, basing on the ascus against colposcopy and biopsy, the non-invasive lesions, then repeat HPV test at a year. If HPV negative, she again returns back to the 5-year screening protocol. If positive, again colposcopy and guided biopsy, which normal, repeat the HPV test at 1 year, and if abnormal, as per the FOGS GCPR guidelines. So, co-testing. Co-testing is the testing of HPV test along with the cytology. What is the importance of co-testing? It helps in identification of the precancerous risk, enhances the risk strategies, as well as helps in detection, early detection of invasive CIN as well as invasive cancers, helps in providing management and allowing palliative care, as much helps us to focus on the women who actually need the treatment, and prevents unnecessary interventions. So the recommendation tool as in a low resource setting, VIA can be used as a screening tool between 30 to 65 years. There is level A evidence in limited resource setting should be at least done 3 times in a lifetime. Screening by VIA should not be continued beyond 50 years, especially in menopausal women, because the transformation zone recedes in the endocervical canal and prevents it from being fully visible. And we all know the importance of the availability of transformation zone when we are doing the PAP test. So the recommendations for the VIA triage tool in basic settings, visual assessment for treatment may be used after positive HPV DNA testing. In cases of abnormal or positive triage results, treatment should be offered. This is again level B evidence. I have actually discussed this in the algorithm shown previously. So coming to the Government of India, what strategies has the Government of India taken by the National Programs for Cervical Cancer Control, which has been started in 1976. Along with this cancer control program, the National Prevention Program for Identification of Diabetes, Hypertension, Cardiovascular Risk and Non-Communicable Disease. All these programs have been interlinked together to start a strategy of identification at the primary level, the secondary level as well as the tertiary level. So at the primary level, there is door-to-door information, education and communication by the accredited social health activists, the so-called the ASHA workers, who provide this primary care information and education to the women. Monthly visits by a medical officer to the sub-center to monitor the ASHA's work and record keeping. Periodic training of health workers in screening. Mass recruiting campaign and periodical screening camps by the medical officer, the health staff of each sub-center. Utilization of the laboratory technician and health workers for screening with cytology and HPV primary prevention. The secondary level, the Government of India, through its various government programs, has started that a gynecologist trained in colposcopy at community health center level, colposcopic equipment availability 1 to 3 per district, and a thermal or a cryoablation unit, a pathologist, a chemotherapy and palliative care services at district level, wherein periodic monitoring and data keeping. At the tertiary level, the improving training in regional care centers and training institutes, infrastructures for radiation and imaging techniques. So a note upon this cancer registries. In India, we do have this cancer registries, which was started in 1982. The National Cancer Registry Program was initiated by the ICMR and it provides a picture of the magnitude and patterns of cancer. The cancer registries are either population-based or hospital-based and provide data to the ICMR on a regular basis. The first rural cancer registry was initiated at Barshi in Maharashtra in 1987. This activity not only increased the cancer awareness amongst the villagers, but also the frequency of early detection, and it reduced the deaths from cancer. This was further extended to other districts in Maharashtra and Gujarat. At present, there are 36 population-based and 236 hospital-based cancer registries under this program. So the cervical cancer screening efforts in India, as we have discussed, availability of screening camps, and most of the clinicians, the obstetricians, gynecologists, along with their hospital setup, go with the camps to the rural services, encourage, empower the women, inform them regarding the availability of vaccination, the importance of screening, and about their symptoms identification and reporting to the health centers. Screening through various village health nurses, then cancer cervical screening modalities as we have discussed via the VIA, cytology and HPV testing. So implementation of HPV vaccination program by the Government of India. Delhi was the first state in India to implement the opportunistic HPV vaccination for schoolgirls aged between 11 to 13 years in 2016. The Government of Punjab developed operational guidelines for implementing HPV vaccination through health facilities with technical inputs from ICMR, WHO and the UNICEF. Sikkim was the first state to completely vaccinate girls aged between 9 to 14 years in the entire state in 2018. So, there is a need for the organizations and the non-organizations like the FOGSI, the Asian Oceania Research Organization in Genital Infection Neoplasia, the most important, the Indian Society of Colposcopy and Cervical Pathology, and the Association of Gynec-Oncologists of India have contributed to cervical cancer prevention strategies by developing certain screening guidelines, conducting screening outreach camps, conducting awareness talks across the country using innovative strategies like the Lifeline Express, to reach remote areas and collaborating with corporate and paramedical organizations. So I'd like to thank everyone for giving me this opportunity, and as a Foxian, I think let's all pledge to do our minimal that we can in vaccination, prevention, screening, because screen the mothers and treat the daughters. I think with that goal, our Foxy President Shantakumari Madam has made a global imprint of our Telugu states with her presence in various international organizations and helping Foxy strike the cancer Mukt Bharat. Thank you.